Air. And I'm here today with my colleague, Mitch Gore, Vice President of Autoimmune Encephalitis Society. And our special guest today is Dr. Sergio Castillo, who now is in Madrid, Spain. Sergio, welcome to On Air.
Thank you, Tabitha, for having me.
You know, the last time we actually spoke on our YouTube channel was a while back, and you gave us that wonderful presentation on the prognosis indicators and functional cognitive outcomes of autoimmune encephalitis. And since that time, you've been really busy. You've got some exciting things going on. So we wanted to have you on and update us on what you're doing. Some of the viewers are familiar with your work. They may know your name. They may be familiar because of all of the research that you've done or seen you on a presentation. But for those who aren't familiar with you, why don't you just start and tell us a little bit about your background so they can catch up?
Sure. So I'm from Spain, as you said. I was born in the north of Spain, and I graduated from medical school there. And then in 2010, it's been a while, I moved to Madrid for my neurology training, and I finished that in 2014. And after that, I worked as a senior neurologist here in Madrid for almost 5 years. Then I moved to France, where I did my PhD under the supervision of Professor Jérôme Honorat, who is one of the top researchers and neurologists in the field. I stayed there with him for 3 years. My research was mainly focused on the associations between autoimmune encephalitis and certain genes that are involved in the immune response, the HLA. And after I completed my PhD, I moved to California in the US to the Stanford University, where I did a postdoc at the Manuel Mignot lab, who is also a top researcher, this time in the field of narcolepsy, but in general in the field of genetics. And I stayed there for a little bit longer than 2 years, 2 years and a half. And then I moved back again to Madrid, and I'm trying to start to create my own lab. That's hopefully happening next year, when I hopefully again will get some funding to start doing some research. Meanwhile, I already created a dedicated clinic for autoimmune encephalitis and also paraneoplastic neurological syndromes, which are, as you know, somehow related conditions. And that's it. That's pretty much a summary of my professional life.
That's wonderful. So when you left Harvard, then you took a sabbatical, is that right?
Sorry?
Did you take a sabbatical after you left
I
Harvard?
mean, when I left Stanford, it
Oh,
was
sorry,
just,
Stanford. Sorry.
yeah, it was just like 2, 3 months before I started working again. But at the beginning, it was only like clinics. I was not having like time dedicated for research. And since February this year, I have a little bit of time for research at my current position.
So, tell us about this new AE clinic. How is it going, and how did you manage that?
So I'm working at Hospital de Octubre in Madrid, which is one of the largest hospitals here in Madrid. And the clinic, the outpatient clinic, started in March, I believe. And so far, I'm mostly taking care of the patients that we are having at our service, our department, which are not so many, but hopefully we will diagnose more and more. And also, I'm hoping to get to get this clinic accessible to other hospitals in the southern area of Madrid, which has no dedicated clinic for this kind of patients. So I think that's a very important thing to start offering specific care for those patients.
What I mean, you're in the bubble of autoimmune encephalitis and paraneoplastic syndromes.
Yes.
Do you get a sense of outside that bubble, how are we doing, how are neurologists doing in even knowing about autoimmune encephalitis or hearing about it or getting to a point where you think this is something maybe I haven't seen before? What do you hear from other neurologists?
Well, I'm not that, I'm not actually so much within a bubble because I also see other patients, not only autoimmune encephalitis, but I think that the funny thing, at least what I'm encountering, is that many neurologists know now about autoimmune encephalitis compared to, I don't know, 10, even 15 years ago, because actually, even when I started my neurology training, that was not something so well known. And it was, what, 15 years ago. um,
Right.
yes. But I think that most of them know what an autoimmune encephalitis is. But the funny thing is that there are still some misconceptions about it. Like, for instance, I think that most neurologists have still the idea of the typical anti-NMDA receptor encephalitis patient. So a young patient with psychiatric disorders or memory issues, seizures, that's an autoimmune encephalitis. But we know now that the spectrum is much wider than that. And that, for instance, patients in their 60s, in their 70s, they can suffer from an autoimmune encephalitis. And I think that's the toughest thing now, the toughest point now, to make neurologists understand that autoimmune encephalitis can also appear in the elderly, or that autoimmune encephalitis can manifest without seizures, or that autoimmune encephalitis can develop more progressively, not so rapidly. So I think that's the difficult part now. So make neurologists understand that the clinical picture is much wider than the original descriptions.
So I did have a question about that, because that's the clinical presentation, as you say, it's evolving, as far as the knowledge basis. But what about the actual testing for antibodies and in cerebral spinal fluid and that is that kind of just stuck in a certain point, or is that also evolving as you're going? Because it's to have a
Um,
you know
I
a
would
positive test
say it's kind of
is
stuck, actually,
yeah.
since that unfortunately the commercial tests that we have so far are not so accurate. So we still need the gold standard techniques, which are mainly in-house techniques that are performed only in reference centers, which I don't feel it's necessarily a bad thing. I think that as long as every hospital or every center make it easy for neurologists to send the samples to reference centers where the diagnosis is accurate and it's reliable. We don't need the commercial kits in every single center. I think it's easier and it's actually better for patients to simply ensure that we are analyzing the samples as they need to be analyzed, not necessary, and that doesn't mean necessary to be analyzed just next to them. Maybe, I mean, for instance, right now I don't perform myself a diagnostic test. I sent all my samples to Barcelona, to Josep Dalmau's lab. I have no issues from my hospital to do so. And I know that the analyses are well done. I received the results very quickly, in 10 days or so. So I think that works and that's reliable. You can be sure that the test is really positive or really negative. So I think that's the main point now. Maybe, I don't know, in the future we will have commercial kits that are more accurate, and that will change the answer for your question. But so far, I would say it's easier to keep doing what we know that works.
Yeah. So, even just to continue with that thought for a minute and move even maybe one step back, your history and your work with Dr. Honorat about or finding genetic predisposition possibilities for autoimmune encephalitis. I think it might be useful for some of our audience members to know at least there's work being done in that area, and to kind of know that it's maybe not quite ready for prime time display yet, but that there's there is work going on for that. Would you mind describing that a little bit?
No, of course not. So we know now that at least some forms of autoimmune encephalitis, principally LGI1 encephalitis, Casper2 encephalitis, and ACLON5 encephalitis, have a strong predisposition, strong genetic predisposition that is related to a group of genes that encode important proteins that are involved in the immune response, that are called the human leukocyte antigen, or a major histocompatibility complex, MHC-HLA. And we know that there is this association that is really strong, is quite preserved across different ethnicities, at least for LGI1, which is probably the best study among these three. So that means that probably these proteins that are encoded by these genes play a role in the physiopathology of these diseases, but we don't know yet exactly what role this is. For other autoimmune encephalitis, there are also several studies, mostly trying to look beyond HLA, performing what is called genome-wide association analysis, GWAS, which are like, let's say, wide genetic analysis, looking for associations with several genetic variants. And for those type of analysis, the main issue is that we really need like large sample sizes to be powerful enough, to have enough statistical power. And as you know, autoimmune encephalitis in general are rare diseases, so being able to gather so large sample sizes has been, I would say, the main issue for genetic studies of such kind. But at least there are some studies in NMDA receptor encephalitis that point towards at least maybe not a gene, but maybe like a genetic region. And actually, there is a study going on now in Stanford, led by Emmanuel Mignot, he's trying to go further and try to actually reveal which genes are within that region or those regions and are actually more likely to be involved in the disease.
Oh, thank you very much. Yeah, that's good. Well, the GWAS studies, as you mentioned, it's sort of the bane of rare diseases to
Yeah.
do GWAS. So
Yeah.
it's hard to get enough samples, but so it's good to know that maybe other air viewers might keep their eyes and ears open for opportunities to contribute. So that's good.
Yeah, in that regard, actually, I would like to add that for such type of studies, it's key to have collaborative studies, multicentric studies, international studies to be able to reach those sample sizes.
Good, good, very good. So on your clinic now, is there a prevalent or evenly distributed across the board, or are what types of cases are you seeing?
So far, since the clinic is quite recent, I have some LGI1 and NMDA receptor, GAD65, some paraneoplastic neurological syndromes. I'm also taking care of patients that develop neurological complications of cancer immunotherapy, such as checkpoint inhibitors. So pretty much that, a bit diverse, but it's kind of related everything. So I like it.
And it's all ages, or is it skewed
No,
skewed in
I'm
any
not.
direction?
No, only adults.
Mhm.
There is a very professional team of neuropediatricians that are taking care of the pediatric cases. I'm trying to work more closely with them. So also to be able to um, take the lead when the patients reach the adult age to start being followed by me. But yeah, I'm working with them, but they are primarily them with who are taking care of children.
It's really so incredibly exciting when you look at where we came from 2007
Yeah.
when Delmo discovered the first antibody and where we are today and kind of going back to what we were talking about before, how for years, if you were a patient, so many doctors didn't know about autoimmune encephalitis, hadn't heard about it, and to see that progress along with the increase of early diagnosis and treatment, which is so key, um, especially being able to identify anti-NMDA more readily and LGI1 because of the seizures that happen with LGI1. We've seen as a patient organization, um, uh, Mitch's wife has a diagnosis of LGI1.
Yes.
And when was she diagnosed? About 6 years ago?
2018. Yeah.
Okay. And how long did it take for that diagnosis to occur?
From first clinical visit or emergency room visit, actually, because of seizures. And we probably about, let's see, it was probably about 5 months, 5 or 6 months. So it was actually,
And
we were very fortunate. It was quick for us.
yeah, and then now to hear Sergio, to hear um, your account that more neurologists are familiar, they know it, they hear it, especially the more common types. Um, we are hearing that a patient becomes ill, reports to emergency department, or they are admitted, and whether they are a pediatric case or whether they're an adult case, when the family members come to us looking for answers, they say to us now, well, they were admitted to the hospital and it took 2 weeks to diagnose this. They just couldn't figure it out. It took 2 weeks. And we're doing backflips, you know? That we're seeing people more and more in not just here in the United States, um, getting a faster diagnosis, where, when you go back to when you first started, it might take a year and a half, um, way back at the beginning, where doctors had to exclude every single possible thing, and because they weren't yet familiar with this new group of diseases, it took longer for an accurate diagnosis. So, the fact that you've opened a clinic in Madrid, it's to us on our side of the bed. It's a huge leap, to see the growth of the awareness happening in this field. It's exciting. So,
I mean, I think, yeah, it's, as you said, maybe it's some patients that are diagnosed nowadays don't realize the huge change. But as you said, us that we saw it. I mean, but I think it's part related to the increasing knowledge, of course, and also related to what Mitch mentioned before. Also, in general, I would say the access to antibody testing is nowadays much easier than 15 years ago. I mean, 15 years ago, I'm not sure, but I'm pretty sure that you have to fill a lot of paperwork to just have some sample analyzed. And nowadays, I think it's, I mean, at least in big centers, I would say it's pretty easy, even if you want to send it to another center with more experience. So I think that's the two main points.
and for people who may have just received a diagnosis for a member in their family, um, the awareness too of not waiting for the antibody testing to come back before you start to treat the patient.
Yeah, I mean, if the suspicion is really high, you don't have to wait, at least for what we call the first line of treatment, which are treatments that are pretty much safe. So we can just give them to the patients, even if we are not entirely sure about the diagnosis. For what we call second line treatment or even third line treatments, which are more aggressive, but many times they are necessary. For
Right.
those, we really need to wait for the antibody testing results. But as I said, if even if when you, at least in my case, even if you send the samples to a reference center, you will have the results generally in 2 weeks. So in general, you can wait for I mean, that much or that long for I mean, before you prescribe the second or the third line. So, but yes, another related issues that some patients are not properly treated, in the sense that are maybe treated only with first line treatments, for instance, or they don't receive more aggressive treatment very early in the disease. Because this is something really important, we have to treat early to avoid, or at least to try to reduce as much as we can the sequela of this disease. And that's another issue that still some physicians or some neurologists don't feel really comfortable with some of those drugs. They avoid them as much as they can, but many patients need it.
Yeah. Are most of this, you can maybe give us a sense of on the second line treatments, even, and even some of the third line treatments, how many of those treatments are technically, say, off label for AE?
Well, actually all of them, because there are no clinical trials in autoimmune encephalitis. That's something for the future, or well, actually for the present. We know that there have been some attempts to run some or the first clinical trials in autoimmune encephalitis. So answering your question, all of them are off label actually.
Okay.
But we have pretty good experience, I would say, for instance, with rituximab in most of the autoimmune encephalitis that are associated with antibodies against neural surface or transmembrane proteins, such as NMDA receptor or LGI1 encephalitis. Some of these patients also need other drugs that have like a wider effect on the immune system, targeting also T cells, which are another type of cells that are not affected by rituximab. And for those, at least I was taught to use cyclophosphamide, and I think most of us use it in those scenarios. But even there are some patients that don't respond to that or to those, and that's something to work on in the future to improve treatments for these diseases. But it's really hard to have good evidence in rare diseases. As we were actually saying before with genetic studies, we have the same problem for clinical trials. It's very, very hard to design and to perform a clinical trial when you have 3 patients in this city, 4 patients in another city. It's really, really hard. But it's, I mean, it has to happen.
Right. Yeah, that maybe in the future there'll be a way to sort of consolidate all those cases in at least in some type of clinical trial, or at least pull data together that would support a larger study, a larger trial. So
And participating in clinical trials is so incredibly important as a patient advocate to let people know, if you're new to this community, if you've just received a diagnosis, to talk to the treating physician about what clinical trials are out there. That's a good conversation, I would think, to have with the family when you're waiting for, your lab results to come back on antibody testing. At what point, Sergio, do you think is a good time to talk about clinical trials with a family or a patient?
Well, I think that either in those cases that are really resistant to the usual treatments, or depending also on the design of the clinical trial, because I'm aware that at least one of them was pretty strict about the treatments that patients could receive before being enrolled. And that's also probably another issue of the clinical trials that have been tried in autoimmune encephalitis, because, I mean, we have an NMDA receptor patient that even if they are going quite well, and you want to treatment with rituximab probably because of the decreased rate of relapses that we know that rituximab provide us. So to prevent a patient to receiving a rituximab against a drug that we don't know if it's having the same effect. It's kind of tricky. So I think that's another point to keep in mind when we design clinical trials, that to be realistic about that, we want for sure to have clinical trials in autoimmune encephalitis, but we want for sure also ensure that our patients are treated correctly. So being extremely strict about the treatments that a patient can receive before being enrolled in a clinical trial, I think that can be an obstacle to develop clinical trials in rare diseases or in severe diseases, in diseases that we know can have important deficits.
Can you talk just briefly about what you as a doctor go through? Now, you know this group of diseases when you think about how you're going to treat your patient. The reason I'm asking is family members will say, well, first the doctor did this treatment, and then the doctor did this treatment, and then the doctor did this treatment. I'm feeling like the doctor doesn't know what they're doing. They actually and this person, the family is in crisis. They're in complete shock. The person was fine. They didn't have any medical history that alerted to anything like this that could happen. And all of a sudden they get dramatically ill, and they're not at all familiar with going to a doctor about a serious illness. So they have no idea what they're seeing. And you can't fault someone for thinking my person got dramatically ill very quickly. Therefore, when my person is treated, we can turn this around and they're going to be just fine, you know. So those thoughts go through family members' minds. They don't realize that it's treated with a combination of treatments. So when you first become familiar with the patient, what can you share about what's going through your mind?
I don't think I can give you the answer that you would like to.
Okay.
Yeah, I think it's much more complex than explaining just I do this, and this.
Right, that's what we say.
Because
There's no cookie cutter treatment,
even for the same disease, each patient is different. And
Right.
yeah, and even if I say before, oh, for this patient, usually we do first line and second line, not everybody needs second line, or not everybody needs third line. So even for the same disease, each patient is different. So there is not like a fixed guide that we are following, and that there is not this, there is some kind of algorithm, but the way we apply that algorithm, it's really different, and it changes from patient to patient. So it's not so fixed, but medicine
This is
generally not
that's
so fixed,
exactly.
and neurology especially is not so fixed. Of course, there are some, let's say, rules or things to take into account, but it's more like the clinical situation that you find, or I don't know, complications that may appear, or maybe you cannot use a drug because there is some kind of I don't know, disturbances on the blood cell count, and then you have to use another one. So it's really a tailored treatment, more or less. We use different drugs, we combine these drugs, but it doesn't have to be the same combination for each patient with the same type of autoimmune encephalitis. It really depends on the severity, if they have seizures or not, if they have more behavioral disturbances, because I'm talking a lot about immunotherapy, but treatment for an autoimmune encephalitis patient is not only immunotherapy. If they have seizures, they need anti-epileptic drugs. If they have behavioral disturbances, they might need antipsychotic drugs. So it's much more wider. So it's not just A, B, C, D, and I follow this line of thinking. It's much more complex, and there are some things that you cannot really explain in words. It's something that you feel that the patient needs, or I mean, of course, based on a lot of things, but
Right.
much more complex than saying, yes, we do this, and if it doesn't work, this. I mean, it's a little bit more complex than that.
That is so important. I'm so glad that you shared that because um, when you're coming into this community, as I said, and you don't know anything at all about what to expect or how something works. And so you want to find out about it. And you join the International Autoimmune Encephalitis Society. We have a huge community online and a private support group that has 4,000 people from around the world that have a diagnosis of autoimmune encephalitis, and they will be sharing their experiences with each other as we are sharing information that research reports. And we are constantly saying what you were just expressing. And that's just so incredibly important for the patients to understand because so often the first question is, what treatment worked for you?
Yeah.
Well, I mean, and I think that's really, that point cannot be overemphasized at all enough because the clinical presentation is so varied. It's just all across the board. And it mimics so many other conditions that, to get a diagnosis is, it's a quite an accomplishment at some point to get a diagnosis, but also to be able to put yourself in a category that would say, okay, here's the clinical presentation that I had, and this is what will work for me, and this is what I should expect for the future. All those things are what the new patient and new caregivers go through, right? They go through all of that. And like you said, it's such an individualized presentation and an individualized response to treatment that you can't really say, by this time next year, you'll be just fine, right? You can't say that. And does that conversation happen with your patients, or is there a way for that to happen?
I mean, most of them, especially those that go well, let's say, they really want to know when they are gonna be perfectly fine, like
Yeah.
person recovered. And regarding that, I have to say that they have to be very patient, actually, because recovery usually takes much longer than getting sick. And that's another thing to bear in mind. And also related to that, I want to stress the importance of rehabilitation, because not only physical rehabilitation for those patients that maybe have some motor issue, maybe like autoimmune ataxias, autoimmune cerebral ataxias, for instance, but cognitive rehabilitation, I think, at least here in Spain, and I would say it's a common problem all over the world, is not something really known or accessible for most patients to find a proper and an intensive program of cognitive rehabilitation. And most patients with autoimmune encephalitis, if they have severe forms, they will need some of that, especially for just, I don't know, recover some memory issues that they may have developed, or to learn new tricks to get into their daily activities, etc. And it's something that I'm encountering here as difficult to give for my patients. So yes, I think that's also something to work on in the future, and I think it's not so hard in terms of that you don't need to develop a new drug, you don't need to develop like huge or very complicated genetic studies. It's just for the people that are in the power to give the tools that the patient need to recover. So
Yeah, and a lot of those tools are there any of those recovery tools that are unique to autoimmune encephalitis, or are they very similar to, say, brain injury from
I
other
would say that the
sorts of?
uniqueness is at least for some patients that they are quite young, and that's something that maybe some like people that work with this on this kind of cognitive rehabilitation, they are not really used to have such young patients and patients that are still or that could be still able to get back to work. That is something that we will have to always try to attempt to achieve with these patients, because it's not like, I don't know, like a patient with in their 80s that maybe okay, you have to try to get them as far as you can, but it's not like a 40-year-old person or a 30-year-old person or 50-year-old person that still have some um, active life, and they have still, or they can even wish to go back to work. So and I have some of my patients that are 20, 30, or even nearly 60, but they want to work, they really want to work, and that's something that they are worried about, to be able to get back to work. And that's something that we will have to be able to help them with.
Good, thank you.
Yeah, that's I call it the donut hole. You know, that's the area that we're advocating so hard gets developed, and uh, we tell our patients it's a journey. This is a marathon. It is not a sprint. Um, this is something that you're going to be working on your recovery for a few years.
Yeah.
And recovery is slow, like snail pace, slow. But I think the miraculous thing on the patient side is there were so many times when I thought, this is it. This is all I'm going to be. This is my baseline. This is my functional level. And I need to find some kind of peace with this. And then I would improve. And it's like, did I see some improvement? Don't, I think I just saw some improvement. And then it happens again. And you think, oh my gosh, I can remember three things where I just remembered two things or one thing. But when I'm on a call and they say, do you want, select one for this and two for that and three for that? I used to and press 0 to replay the menu. My husband once said, honey, you have pressed 0 to replay the menu 5 times. I've been listening to it because I had my phone on speaker. And I was writing them down because I couldn't remember, which number do I press. And one day I made a call and they said press 2 for, and I thought it's 2. They, 3, 4, it's 2. I want 2. Oh my gosh, I just remembered more than 2 or 3 options. It is painstakingly slow. You don't expect, you get to a point as a patient, you're surprised, you don't expect it. Other family members have said, okay, I'm going to find peace with this is where my loved one's baseline is. And you're a year and a half, 2 years out, and you just saw this increase. And even though it's small, it's not to the patient because it begins to apply across all settings and situations as we manage it. So when you look back on your journey, and maybe you're 5 years out, and pretty much at 5 years, I think what you see is what you get. That's not to say you're not going to see another bit of improvement, but you're you're pretty much where you are. Yet at the same time, because of all of the coping strategies we've implemented into our lives to support our lasting deficits, we're managing and out there being involved in life in ways that we never imagined in our first year after onset we would ever be. And that is the most amazing thing.
Yeah, well, there is hope, that's for sure.
Yeah.
There's certainly a lot of hope, and I think, while like you say, the journey is slow and the journey is protracted, sort of long. I think there's the improvement in the rapidity of diagnosis, and also just the general knowledge of of AE in the medical community is just it's a wonderful thing, right? So it's means that people are getting help a lot faster than they used to, and that also help is available. You don't have to search and search and search for someone that knows anything about AE in the medical community. I think we're past that point. Although finding the right treatment course and because it's so individualized is somewhat the challenge still. But we have folks like Sergio that are there and helping to get that done. So that's good.
And it's exciting. It's just so exciting to see where we were and where we are and know that the future is going to be brighter on both sides of, bench or bed. Um, it's kind of like Mardi Gras, the best, seasonal holiday or birthday gift you can possibly receive, with the excitement that we feel about how we're watching this young group of diseases. It hasn't been very long. That's a nanosecond in science where
It has changed it all
it's
in
amazing.
neurology. Yeah, no, definitely.
And the passion that you have, and that others in the field have in moving the ball forward is really exciting for us to see.
Well, it's also exciting for us to contribute to know much more about these diseases and also to take care of our patients.
So, Sergio, in the description of the video, I'm going to put your contact information.
Sure.
So patients know where you are, doctors know where you are. Um, and in the future, let's touch base again and see how you're doing. And colleagues of yours are welcome to come on air and share with us as well. Um, this has really been a lovely conversation, and I want to thank you for joining us today.
Thank you for having me. Thank you both.
No, thank you.
Yeah, truly.